inhibit, GPI secretes their own GABA. Is that clear, folks? Now the basal ganglia, especially striatum, they are secreting their own GABA in a different location. That GABA is blocking the GPI. So the GABA cannot secrete their own GPI. So therefore, no inhibition of thalamus. Is that clear, folks? So now what happened? I am able to move. All the move can be done. Why I'm able to move? Your thalamus is free. Okay, your thalamus is free. So that making a move is called direct pathway. Is everybody clear, folks? So direct pathway. Anytime I say I'm stimulating the direct pathway, that means I wanted to make a move. Is everybody clear, folks? So who makes the direct pathway? When somebody's at rest and if they want to make a move. Now, what have I explained? I give you the filtered information of this, folks, okay? Direct pathway is also known as excitatory pathway because that makes you to move, folks, okay? Look at this. GABA release from GPI is inhibiting, activating the thalamus, increase motion. Is everybody clear, folks? I literally took this paragraph and I gave it to you in the points form. Go ahead and write this down. So anytime I would say that I'm stimulating the direct pathway, that means I'm trying to make a move. Is everybody clear, folks? Okay. Exam will not ask you this pathway, but you need to understand this pathway, how it works, so you understand the diseases. Everybody clear, folks? Okay, so one more time. Direct pathway means we are activating a pathway to make a move. When somebody's at rest, their thalamus is inhibited by GABA that comes from GPI. So for me to make a move, I have to inhibit the GPI. So striatum secretes their own GABA. That GABA comes and inhibit the GPI. So there's no other GABA to block the thalamus. So therefore, thalamus is free and you're making a move. Everybody clear, folks? Okay. Now, when somebody is in the move constantly, you need to stop a move, folks, okay? So let's say you are walking on the street, right? And you see a huge wall in front of you. Are you going to just keep walking on the wall? No, you need to stop. Otherwise, you will hit the wall, isn't it, folks? So then we need to stop the move. So I need to stop. I need to stop the move. Okay? We need to stop the move. This should be easy now. How do you stop it? Somehow you have to bring the GPI back. Is that clear, folks? If you bring the GPI back, you will easily block it. So again, to stop a move, we call it, it's an indirect pathway. Indirect pathway. Indirect pathway signal come from cortex again, that goes to the striatum. It always has to go through the striatum. If you hear that, that's your indirect pathway. Cortical input that stimulates striatum. Again, they are releasing GABA from striatum. Okay. Now, what's happening here, a little tricky. Striatum is releasing a GABA again, but this time, this GABA is blocking a GPE. Okay. This GABA is blocking a GPE. By blocking the GPE, you are activating GPI. That's a part here, folks. Okay. I want you to memorize it like that. So here, striatum is secreting the same GABA. That GABA is blocking the GPE, globus pallidus externa. Once you block that, your GPI become active. Once GPI become active, they're going to secrete their own GABA. That GABA will block the thalamus and it will make the patient to stop. Is that clear, folks? Okay. Now, I know you are seeing so many GABA. Remember, folks, it's all about GABA. It's all about within the basal ganglia, where they bind and who they stimulate is what matters. Is that clear, folks? Now, the bottom line, after you learn this, okay, after you learn it, write this down. I'm going to rewrite again a different form. Now, if you see here, I could simply say you have a thalamus. Okay, you have a thalamus. To make a move, so direct pathway. Direct pathway makes thalamus free so you can make a move. Is everybody clear, folks? Direct pathway make the thalamus free. How do they make the thalamus free? They inhibit GPI. Is everybody clear, folks? Anybody don't understand that? Okay, direct pathway inhibit the GPI. If you inhibit the GPI, your thalamus is free. Indirect pathway, on the other hand, stimulate the GPI. It stimulates the GPI, so that blocks the thalamus. Is that clear, folks? It blocks the thalamus, so no movement. Direct pathway, yes, movement. That means you move. Indirect pathway, no movement. Is everybody clear, folks? So if somebody is at rest, we stimulate the direct pathway. If somebody is in the move, we stimulate the indirect pathway so you could stop the move. Is everybody clear, folks? Anybody don't understand that? Okay, so that's your direct and indirect pathway, folks. Okay, again, it's all about activating thalamus. I could also say when the thalamus is free, you can move. When the thalamus is blocked, you cannot move. Are we clear, folks? Now, why do we need to learn all these things? The last thing to learn, direct pathway has D1 receptor. Indirect pathway has D2 receptor. That's the bottom line, folks. That is the whole idea. D1 is direct, D2 is indirect. So can I say if I stimulate D1, I make a move? Yes, no? Okay. So if you stimulate the D1, you make a move. What happens if I stimulate the D2? You stop the move. Is that clear, folks? Who binds to D1 and D2? That's your dopamine. That's your dopamine. That is the final part. This is what we need to learn. I have to do all these things to make a sense out of it. Now, if you see, dopamine comes out, they stimulate D1, they inhibit D2. That means dopamine helps to make a move. Is everybody clear, folks? Look at what dopamine is doing. Dopamine is stimulating the direct pathway and inhibiting the indirect pathway. So that helps a human to move, make movement. Is everybody clear, folks? So when you have dopamine, this is what happened. Write that down. That's a normal physiology. That's what happened in the human body when they have dopamine and stuff. That's normal.
Right. So you're saying dopamine is the one that basically stopping the movement, or
no, I didn't say it's stopping the movement. Dopamine binds to D1. That means it makes the move. And in order to make a move, you shouldn't stimulate the indirect pathway because we said indirect pathway stop the move, right?
Yeah.
Direct pathway.
I mean, that's what it's caused by dopamine. That's what I meant. right?
Dopamine stimulate this pathway, inhibit this pathway. So if I want to make a move, I want direct pathway. I do not want indirect pathway. Do you get that? So
Yeah.
what dopamine does, it stimulates the direct pathway, inhibit the indirect pathway, so which means it's easy for me to move. Because if you don't block the indirect pathway, what will happen? They will also stop the move, isn't it? Are you guys getting this?
Then where is dopamine located at?
What do you mean dopamine located at?
I mean, you know how we talked about GABA?
Hmm.
It's released by striatum, right? So I'm trying to figure out where is dopamine coming from in here, in this pathway.
In this pathway, this pathway has a receptor. In the striatum, they have a D1 and D2.
Yeah.
So
Okay.
the dopamine comes and stimulate this and inhibit this.
So it's in striatum. That's what I meant to ask,
Yeah.
right?
It comes to striatum, but it's not produced in striatum.
D1 and D2 is not produced in striatum?
D1 and D2 is in the striatum, but dopamine is not produced in the striatum.
Okay. Thank
Where
you.
does dopamine comes from? Where is dopamine produced?
Substantia nigra.
Substantia nigra. Okay, so it produced in the substantia nigra and it comes and bind to the receptors in the striatum. Is that clear, folks? Okay, now dopamine comes and bind to the D1 and D2 receptors in the striatum. It binds to D1 and stimulates it. It binds to D2 and inhibits it. Is that clear, folks? When you have this, you have a movement. Clear, folks? Anybody still don't understand this? Now let's see the opposite. What happens if I don't have dopamine? No dopamine. If you don't have a dopamine, D1 will be inhibited and D2 will be stimulated. Opposite. When you don't have a dopamine, it's this opposite. So which means without dopamine, you think it's easy to move around? That's your Parkinson's disease. This is literally the finding of Parkinson's disease. In Parkinson's disease, D1 is inhibited and D2 is stimulated, therefore no movement. Patients are stiff. Is that clear, folks? Isn't it the problem with Parkinson? Okay, so that's the bottom line. When you have a dopamine, dopamine stimulates D1 and inhibits D2. When you don't have a dopamine, it's going to be opposite. D1 will be inhibited. Why D1 is inhibited? Because there's no dopamine. Dopamine is the only one can stimulate it. Is that clear, folks? Are you guys getting this clearly? That's the most important, okay? That's why we are doing all these things, okay? Now, if you see here, dopamine comes from, what does SNC stand for? Substantia nigra. What does that C stand for?
The compartment or comparta, something like that.
Good job. Substantia nigra has two parts. Pars compacta, pars reticularis. But only compacta produce dopamine, not reticularis. Okay. So in the exam, they could ask you where specifically in substantia nigra your Parkinson's disease is affected is pars compacta. That's what the C stand for. Pars compacta. Now you could see dopamine stimulates the direct pathway, which is D1, and inhibit the indirect pathway, which is D2. That's what I wrote it, isn't it, folks? That's the idea. So in this page, I will write on the bottom here, just one more time, D1 and D2. Dopamine stimulate this, inhibit this. By doing that, increase motion. Is everybody clear, folks? I'm just rewriting the same thing, folks. When you have dopamine, D1 is stimulated, D2 is inhibited. So therefore, I'm easy to make a move, folks. I could simply say, whenever there is a dopamine, your thalamus is free. How many people agree with me? Whenever there is dopamine, your thalamus is free. Agree? There you go. Because when they stimulate that direct pathway, your thalamus become free, right? Okay, I could even write it here. Thalamus, free and activated. Free and activated. Now, when there is no dopamine, I'm just want to write this. No dopamine. D1 is inhibited. D2 is stimulated, is opposite. Therefore, decrease motion. And what happened to thalamus here? Free or inhibited? Inhibited, there you go, perfect. Just to understand these two lines, we have to go through the whole thing, okay? But now it makes sense for you guys, right? What's D1 and D2 rather than memorizing, okay? That is the key here, folks.
Can you see the diagram that you just drew? Not this one, the other one, the first one.
This one?
The other one, the one before this.
This one?
Just one last thing. When in indirect pathway, when GPE inhibit GIP, right?
GPE is inhibited, therefore your
Inhibited.
GPI is active.
Active. That produces this GABA, same
And
as
that
how it
blocks the
produces.
thalamus.
That's what I meant. That's the same as how it produces in direct pathway, right? Right.
Yeah. Yeah, same thing. Yeah, I just wrote it twice. Any other questions? Okay. All good here, Alize? Can I move, Alize? All right. So did you guys copy this? All right. So the dopamine is to move. When there is no dopamine, you cannot move, folks. Okay. So that's the basics of basal ganglia. If you know this and the locations to identify, you should not have any problem. Any question before I move to pathology? No pathology. Okay. I'm going to go find movement disorders, and we're going to do movement disorders now. Okay, go to page 537. Okay, now when it comes to movement disorders, folks, okay. Asterexis, athetosis, all these are symptoms. These are not diagnoses, and some of them we already covered, okay. You guys have to read it. I'm only going to cover the diseases here. These three are considered the most important, okay. We use the word asterexis many times, so you guys should know by now what is asterexis. That's a flapping tremor due to basal ganglia, right? All right. These three tremors become sometimes very difficult to differentiate. Let's first start with resting tremor. Whenever we say resting tremor, I know you guys think of Parkinson's disease. That's where it happens. What is resting tremor? A patient is at rest. Let's say I'm the person, I'm at rest. They have a tremor. This is exactly how they shake usually in Parkinson's disease, right? There's a lot of tremor when they're resting, it's very bad. These people cannot even eat their own meal. If you've seen a severe Parkinson's disease, they cannot even hold anything in their hand. It's like pretty bad, guys. It's like really bad. Okay. So we call it this a resting tremor. Students get confused. So when people are at resting tremor, what happens if these people try to move something? If they try to do something, does the tremor goes away? It does not go away. See, that's where the mistake comes. I thought the same thing when I was a student. Parkinson people have the resting tremor, but when they try to do something, they still have tremor, but the amplitude of the tremor is reduced. Is that clear, folks? Why am I saying this? Because on step 1, they put a video for this. So they show a video, and you have to be very careful, because when people see it, they think it's an intention tremor video. Most of the people, it's not. So look at this. I have a very bad tremor, but when I'm trying to do something, it's slow, but I still have tremor. Does that make sense, folks? So don't think resting tremor mean it disappears when I move. Is that clear, folks? So resting tremor means the tremor is high at rest. You still have tremor when I'm moving around. Is everybody clear, folks? That's the idea, okay? So that's your uncontrolled tremor. So that's your resting tremor. Now compare that with essential tremor. Essential tremor means when you ask the patient and you tell them to stay in a specific position, I'm telling them, okay, hold the hand like this. They are staying in a very specific position. They are not doing anything. They are staying in a very specific position. And when they do that specific position, they shake. These people, they shake when they have it. That's essential tremor, folks, okay? Now, if you see, it's a high frequency tremor with a sustained posture, outstretched arm. So you tell them to do something and hold on to like that, right? That's basically it. That's your essential tremor. It happens when people are nervous, anxious. Is that clear, folks? That's the idea. Now, it's often familial. Patients often self-medicate with alcohol or some medication, right? Beta blocker or Primidone. You need to know that, Primidone. They take the medication, folks. So if you want to check these people, we simply tell them, hold a hand like this for me. And when you look at them, you could see they have a tremor in their hand, folks. That's essential tremor. The last one is intention tremor. Look at the word. Intention tremor is you are sitting, no problem, but you try to do something. When you are trying to do some activity, then you have a tremor. A good example, the patient tried to reach the coffee cup, and while he was trying to reach the coffee cup, he take the coffee cup and he spill it because he's trying to do something. Is that clear, folks? That's intention, that they are trying to do something. When they're trying to do, you have a tremor, folks. That's intention tremor, okay? Now you could see it's a slow zigzag motion when pointing or extending toward a target. Recently on the step 1 exam, this came, the question explained this patient was trying to get a TV remote and he couldn't get the remote and he dropped it. That's an intention tremor. Is that clear, folks? Because you are trying to do. Another example, let's say you are doing a surgery rotation and your surgeon or your professor stand next to you and give you the stitching kits and say you start stitching. Do you think you will stitch it properly? The hands will dance in there because you are nervous and you are trying to do something. Stitching is trying to do something. What type of nervous tremor is that? Intention tremor, because you are trying to do something. Is that clear, folks? So that's intention tremor. Unfortunately, it's a cerebellar problem. There's no treatment you could do. When people have intention, they have to train. That's all they have to do it, folks. Okay? They have to train.
Dr. Roy, I have a question. Which one of these which one is present in hypothyroidism? Like you, while testing for hypothyroidism, you ask the patient if the handshake.
Essential tremor.
Got it.
Okay. So that's essential tremor. So to recap all the 3 types of tremor, resting tremor happened when you are at rest, but then you still have it during activity, but it's reduced. Now, when it comes to essential tremor, When you ask the patient to stay in a specific position, they have a tremor. That's essential. Intention tremor is when you ask them to do certain things or activity, they have tremor, pointing towards a target, grabbing something. That's intention tremor. Are we clear, folks? That's your 3 different types of tremor. Okay. Now, that's the most important in this page. Let's go to the next one. Here, you have a disease called neurodegenerative disorders. Page 538 and 539 is the most important of neurology, folks, actually. These 2 pages will easily bring 5 questions on your step 1 exam. The most important page, I would say, in neurology here, folks. These are neurodegenerative pathway. What does that tells you from the word? There's no treatment or cure because it's degeneration. You could only manage it. Is that clear, folks? All right. Now, when people come with this disease, they have a decreased cognitive ability. What does that mean? Judgment, thinking, those are impaired. Memory is affected. The only thing is intact consciousness. They don't lose the consciousness, folks, okay? Other than that, memory and cognitive is affected. We should always rule out depression because there's depression can cause dementia in people sometimes, folks, okay? In that, and then, rule out the hypothyroidism, vitamin B deficiency, all those things. Let's start with the first disease, Parkinson's disease, folks. Now, what's the problem with the Parkinson's disease? Loss of dopaminergic neurons. There's no dopamine in substantia nigra. Look at that, pars compacta. Only pars compacta is affected, not reticularis. Is that clear, folks? Old NBME, they removed that. Old NBME used to have a question. Which of the following is affected in Parkinson's disease? They give you pars compacta as one option, pars reticularis, okay? So that NBMEs are gone, but still it's a concept. So when you have no dopamine, there is no dopamine, what will happen in this patient? D1 inhibited, D2 stimulated. Is that clear, folks? This is what's happening in this patient. People with Parkinson, that's a finding. What happened to the thalamus? Activated or inhibited? Inhibited, okay? Inhibited, very important, folks, okay? Thalamus is also inhibited. So that's your Parkinson's disease. Sometimes we have this Lewy body, we find it. These are alpha-synuclein eosinophilic inclusions, folks. Okay, those are finding. Symptom. They have a tremor, that resting tremor, rigidity. Sometimes people get confusion. What's rigidity mean, folks? They are basically stiff. Their hand is very stiff. It's not easy to move around, okay? And then they have akinesia. We understand the pathology. Parkinson's disease, people have difficulty making a move. Is that clear, folks? That's a problem. So they take long time to do everything. Postural instability, shuffling gait, small handwriting, micrographia. Because in order to write, isn't it, your hand has to move? If their thalamus is inhibited, it's very difficult for them to move. Is that clear, folks? All right. That's the idea. Dementia is usually a late finding. That's a late finding for Parkinson's disease, okay? Now the last one, MPTP. It's a chemical. It's an abbreviation for a chemical. It should be on the back of the book. I don't know what's an abbreviation, but I don't think we need to know. MPTP is a chemical found in many illegal drugs. When people use the illegal drug at a younger age, that illegal drug has that particular chemical, which is toxic to substantia nigra. So what happens, folks? When people use illegal drugs at a young age, they will become Parkinson's disease in their 50s, and they will know why they got the Parkinson's disease. It's because of that drug use. Is that clear, folks? All right. So that's the idea here, folks, okay? So that's Parkinson's disease. So everybody clear with Parkinson's disease?
I'm not sure if you explained this before, but can you show us what pill rolling tremor looks like?
It's basically, it's like a little tremor in the fingers that happen like that's without their control, they will keep doing that. That's what it's a resting tremor that looks like a pill rolling. That's all. Yeah. Okay. So that's Parkinson's disease. Next, Huntington disease. When you see Huntington disease, it's another autosomal dominant 5-nucleotide repeat. CAG, you must remember that. Okay. What's the other trinucleotide we studied yesterday? Type it up. Name of the disease. Why is it taking so long for the rest of you guys? Friedreich's ataxia. Okay. That's Friedreich's ataxia. Here it's in chromosome 6. There's a toxic gain of function. Symptom manifest between age 20 to 50. Now, if you see these people have chorea, abnormal movement, apoptosis, aggression, they can get very angry, depression, and dementia also sometimes. Okay. Now, anticipation is a result of this. Primary. So what is anticipation? Each generation will get the disease earlier, folks. Okay. So if let's say if I get Huntington at 50s, my kids will get it in their 40s, and their kids will get it in their 30s. That's the anticipation. Each generation can get earlier. Now, one of the most important things, it's the cowardly areas that's affected in Huntington disease, folks. Okay. Now, even though the book says atrophy of caudate and putamen, it's caudate hands. Okay. Caudate hands. The next thing you need to know, people with Huntington has increased dopamine, decreased GABA, and decreased acetylcholine. Okay. Decreased GABA and decreased acetylcholine. And those also neuronal death. Now, if they ask you, which of the following is which of the following one is decreased in Huntington disease, they give you both GABA and ACTH. Which one do you pick? With both are networks. They want to know which one is more specific. Answer is GABA. Okay. Because why ACTH is also produced in different parts of our brain, so it is not specific. Okay. GABA is unique because it produces carefully, folks. So GABA is just the answer to that. Okay. Now that's Huntington disease. Very clear. Next, Alzheimer's. Now, when it comes to Alzheimer's, that's the most common cause of dementia. I know that's the number one cause of dementia. What does that mean? That means no judgment, no memory, nothing. That's the dementia, right? Advanced age is the strongest risk factor. Down syndrome patients have increased risk of developing this early. Down syndrome people develop Alzheimer's early because the APP gene that is located on chromosome 21, Down syndrome people also have affected in chromosome 21. Isn't it, folks? All right. Alzheimer's disease has decreased acetylcholine. It's due to acetylcholine transference activity. Okay. Now there's this talking, folks. People who has APOE2 protein have an increased risk of sporadic form. So if you have more APOE2, you have less chance to get Alzheimer's disease. If you have APOE4, then you have increased chance of getting Alzheimer's. Okay. Now just to talk about it, there was an article released in Psychiatry. They say people who eat very spicy, there's some chemical in your food, I forgot. It stimulates more ApoE2. Okay. So people who eat more spicy food, they tend to have more ApoE2, which means they have less chance of developing Alzheimer's. But they have more chance of developing ulcer in the stomach. Okay. So that's that. By the way, if I have a gastric ulcer, what blood vessel am I bleeding from? Type it up. If I have a gastric ulcer, which blood vessel am I bleeding from? Gastric ulcer, which means I'm talking about stomach. What artery? If I have gastric ulcer, I will never come to one of you guys if you guys are practicing medicine. You guys will kill me. It's left gastric artery, gastric ulcer. Gastroduodenum is for duodenal ulcer. Okay. So it doesn't matter whether it's a, gastric ulcer most commonly happens in laser curvature, but you cannot bring gastroduodenal artery in there. That's in duodenum. Okay, folks. Now you see, here I could say wrong, you will pick the right answer, but in the exam you will click on move on. Dr. Roy is not there to say it's wrong. Okay, careful folks, first choice. This is what it is. Okay. Now, anyway, so that's it. There's another protein, APP, presencilin 1, 2, all those are familiar form, earlier onset. Whenever people have that, they get that earlier, folks. Okay, so that's about.
Apart the chemicals that was present in, that would affect ApoE2. Were you talking about capsaicin?
Yeah, I'm talking about the capsaicin. That's what I was looking for. Okay, so the capsaicin and the spicy, that's what affect. It increases the activity of ApoE2, folks. Okay. Now, people have diffuse cortical atrophy. When you have a diffuse cortical atrophy, can we see ex-vacuoventriculomegaly? We do see ex-vacuoventriculomegaly. Okay. What is ex-vacuoventriculomegaly? The tissue is atrophied, so that makes the ventricle look bigger. Okay. That's Alzheimer's disease. Now you also have atrophy of hippocampus. Remember, hippocampus is important for memory. There's some senile plugs that can cause amyloid angiopathy and stuff, and it can give intracranial hemorrhage. But for me, the most important is neurofibrillary tangles. Neurofibrillary tangles are intracellular hyperphosphorylated tau protein. Okay. Now, what do we need to know? Number of tangles correlate with the degree of dementia. What does that mean? Let's say if I have a patient who has Alzheimer's, the patient's family comes and asks me how bad the Alzheimer's is. I would say I need to know the number of neurofibrillary tangles. If the patient has less number of these tangles, that means better. If they have more tangles, that means it's more severe. Is that clear, folks? The more the number, the bad it is, folks. Okay. So the prognostic factor of Alzheimer's disease is number of neurofibrillary tangles. Is that clear, folks? That's very important. Okay. Nobody can tell how bad it is without checking the neurofibrillary tangle on MRI, folks. Okay, that's important. Okay, that's very important. So they have to know that. So that's the key here. The last one, there's something called Hiranobodies. These are intracellular eosinophilic inclusion in hippocampus. That you should know that where the Hiranobody is found, it's in hippocampus. That's Alzheimer's. Are we clear, folks? Okay. Now, next one, frontotemporal dementia. What's the function of frontal lobe? It's a personality, right? Frontal lobe is your personality. In fact, frontal lobe works with your limbic system more. So that creates your behavior and personality. And temporal lobe is for hearing, right? So when people have frontotemporal dementia, you could see it's formally called pig disease. Early change in personality and behavior, folks. Okay, that's the idea. And the frontal lobe and also temporal lobe have your Wernicke's and Broca's area. So they could even have aphasia. We'll talk about that today. And they have some movement issues with that, folks. Okay. Frontotemporal lobe degeneration. That means in this particular disease, only frontotemporal lobes are affected, nothing else. There's some inclusion, staph protein, pig bodies. Okay. So that's frontotemporal dementia. Are we clear, folks? Okay, let's continue. The next one, Lewy body dementia. Lewy body dementia. It's a visual hallucination with dementia, fluctuating cognition, and all these things, folks. Okay. REM sleep behavior disorder and Parkinsonism. It's also called Lewy body dementia if cognitive or motor symptoms last for the less than more than a year. Otherwise considered dementia secondary to Parkinson. To make it easy, this disease, Lewy body dementia, the best way to remember Parkinson disease with hallucination, Parkinson plus hallucination. If you read that and you pick those two, Parkinson plus hallucination, then you will think it's a Lewy body dementia because Lewy body is found in Parkinson, isn't it, folks? All right, so that's that. Vascular dementia is a high yield topic. What does vascular dementia mean? That's your stroke. People getting stroke is the second most common cause of dementia in elderly people. You see that? What's the number one? Alzheimer's disease. Number one cause of dementia is Alzheimer's. Number two is stroke. When people get stroke, this is what happens, folks. Now let's talk about stroke. Now this is the time we're going to go back and talk about stroke. Let me go find stroke section. Here, page 529. We're going to talk about stroke. Now, while you have that page, so let's say, not even both. So one branch is good. Okay. So this is an artery. This goes to different part of the brains, folks. Okay, one artery. So I could have a clot right here. If I have a clot right here, do you think the oxygen can go there? No, that is called ischemic stroke. That's one category. So why do we call it ischemic stroke? The blood vessel has an embolism, it's completely blocked. So the distal part of the brain or whatever the area is not getting blood and they're going through ischemia. And we know brain neurons will die fast if you don't take care of it. That's one type. Second type. Imagine the blood vessel is ruptured like this. If the blood vessel ruptures, what will happen? All the blood will bleed here, isn't it, folks? All of them will come out here. That will reduce the blood that going to the distal part. Are we clear, folks? That is called hemorrhagic stroke. That is called hemorrhagic stroke. So there are two types of stroke when patient gets stroke. Hemorrhagic stroke or ischemic stroke. When they come to the hospital, unless you're a neurologist, it's almost impossible to tell whether the patient has ischemic stroke or hemorrhagic stroke. Is that clear, folks? All the symptoms are same. Nothing you can find it. Even neurologists, they will guess it, but they will never confirm it because if they are wrong, their license is gone. Okay, so we have to do imaging to confirm it. Is everybody clear, folks? So when patient comes with stroke, they both will have the same symptoms, but one is a blockage, one is a bleeding. You could ask me, they might have a very low blood pressure. You cannot bleed that much inside the brain to have a low blood pressure. Is that clear, folks? These are little bleeding, right? So you don't see a difference. Okay. So that's two types of stroke: ischemic stroke, a hemorrhagic stroke. So when a patient comes to the hospital with a sign of stroke, we don't know which one they have. So the first thing we do a CT scan of the head, CT head. What is the most special? You have to do a non-contrast CT head. That word of non-contrast is the most important here. Why? Let me explain. When the patient comes there, I don't know if they have a ischemic or hemorrhagic. Let's say I'm giving a contrast. What is contrast? Chemical that goes inside here, blood vessel, right? In case if they were to have hemorrhage, that contrast will bleed or leak through that rupture. It will cause fibrosis of the brain. It's toxic to brain. So when the patient comes with a stroke, we don't know if it is ischemic or hemorrhagic. So we always go without a contrast to be on the safe side. Is that clear, folks? So the first CT is a non-contrast. After you do a non-contrast, and if they confirm it's ischemic, then we will do second CT with contrast, because now we know it's not a hemorrhagic. Is that clear, folks? So they have to do it twice, okay? So that's very important. Is everybody clear, folks? Now, if you see the book, stroke imaging, what do you see? Non-contrast CT to exclude hemorrhage. Is that clear, folks? You cannot, okay? And you cannot also give TPA. Remember, folks, unless you do non-contrast CT and confirm ischemic, you cannot give TPA. What happens if you give TPA to a hemorrhagic stroke people? You will expedite their death. Why? They're already bleeding. Giving TPA makes the blood become even more thinner, and it will bleed even faster. Is that clear, folks? So that's the idea. So you cannot give until you do that. Okay, that's the key. Now you could see here some interesting features. CT detects ischemic changes in 6 to 24 hours from the onset of symptom, whereas MRI can detect 3 to 30 minutes. That's amazing, isn't it, folks? Then how come we don't do MRI for stroke? We always do CT non-contrast. If MRI can detect in 3 minutes, why cannot we do? Price-wise, it's like a $200 different. Not a big difference.
Because the MRI takes much longer.
Negative.
God forbid, if it's an emergency and they have some form of metal on them, like earrings or something, that can cause issues too.
True, but the most important thing, there is no way you could do MRI without contrast. That's the reason, okay? Of course, these metal things, all those are there. That's no matter what. If you see MRI, they get a specific chemical, it's called gadolinium and all these substances, right? Almost impossible to do MRI without contrast. Is that clear, folks? So that's why we have to stick to non-contrast CT head, folks, okay? Of course, it's both are expensive. How much do you think the CT of the head cost? Take a guess. You guys are doctors. Come on. CT head costs about $3,000. Okay. And then MRI will be like 3,500. That's all it is. Okay. So that's the idea, folks. Okay. Now, this is how we picture this. Now look at this. Irreversible neuronal injury begins after 5 minutes of hypoxia. The most vulnerable areas are hippocampus, folks. You should know that. Hippocampus, even though they say neocortex and cerebellum, hippocampus. What does that mean? When people have a stroke, and if you don't do things faster and recover, the hippocampus will be affected and they will have memory issues. Is that clear, folks? All right. That's that. Now let's go talk about treatment a little bit here. They're talking about the ischemic stroke, right? There are 3 types of ischemia you could get. You could get embolism. That's what I explained. You could also develop your own embolism, what we call thrombosis, isn't it, folks? Okay. And then, of course, hypoxic. That means low oxygen due to any reason, right? You could have some cardiovascular issues, cardiac output, anything. All 3 of them literally cause decreased oxygen perfusion to the tissue. Is that clear, folks? All right. That's the idea. Treatment. You have to give TPA within 3 to 4.5 hours of onset, as long as you know there is no hemorrhage. Why do we have to give within 3 to 4.5 hours? Type it up. Why do you have to give within the first 3.5 hours? What happens if you are late? Connect this with hematology, folks, what we studied. Why do we say when patient comes with stroke, try and give TPA within 3 hours or as soon as possible? Because after 3 to 4.5 hours, something else will come there. Another stroke. Damn, did you guys all have dementia? Any stroke when you slept last night? After 3 to 4.5 hours, factor 13 comes and make the clot more stronger. Do you guys remember? We did clotting factors, intrinsic and extrinsic, and we said the primary clot and the secondary clot happens when the factor 13 comes, right? So we wanted to give the medicine within the first 3 to 4.5 hours so the factor 13 don't come. Once factor 13 comes, it makes it a little harder to break down clots, folks, okay? That's the idea. All right. So if you cannot...
Does this have to do with the symptom-wise? Because I remember when my dad had a stroke, they only gave him aspirin at the hospital, and then 4 days later, he had like right upper weakness in his arm and his leg. Then they gave him clopidogrel and aspirin.
Question number 1, this has happened in the United States?
No, of course not.
Okay. So I'll tell you, every country has their own protocol. It's different. And did they take a CT scan as soon as your dad went to ER?
They did, but nothing showed on it. But then
Okay.
days later showed.
Okay. So according to their theory, if they don't have anything on the CT, they cannot, there's no need to give a medicine. That's why they give aspirin, right? So again, here they're a little careful, but that's the problem with outside, right? So that's the idea. All right. Okay. So now you see, reduce the risk with medical therapy such as aspirin and clopidogrel. You know, what does aspirin and clopidogrel do? It's platelet aggregation inhibitor, isn't it, folks? All right. So now keep in mind, giving aspirin for future. If they have not developed a clot, it will inhibit the formation. If they already have a clot, they don't. So one of the reasons maybe they give it to your father because they took a CT and it's negative, so they gave aspirin in case, but then he still developed it because the aspirin was not strong enough to prevent his clot. Is that clear, folks? All right. And then they have to do optimum control of blood pressure, blood sugar, lipids, and smoking cessation, and all these things. Okay. So that is stroke. Is everybody clear here, folks? Okay, that's stroke. Now, there's a milder version of stroke, what we call TIA. TIA, it's like a warning sign people get. It's like a quick thing that comes and goes. It's indirectly telling you have a lot of atherosclerosis in the cerebral arteries. Is that clear, folks? So it's like a warning sign. Some people are smart. They pick up that warning sign and come to the ER, so they will never get stroke. Some people ignore it. Okay. Now, if you see, it's a brief, reversible episode of focal neurological dysfunction without infarction. Okay. Now, they say it's less than 15 minutes. It's actually less than a minute sometime. It's like, let's say you are sitting on a coffee shop and you are drinking coffee. For like 10 seconds, you pass out and you come back. 10 seconds. What do you think when it happens? Oh, I'm tired, I'm falling asleep. That's what called TIA. It's like a quick thing, right? So that's the idea, folks, okay? May present with some amaurosis fugax. What is amaurosis fugax? It's usually they say you're losing a vision. It's like a curtain coming down and closing it, you see? And then goes, that's what it is, folks, okay? That's because you have a small clot in the retinal artery. That's even worse. Like imagine you are sitting there and you feel like a curtain coming down and then it goes back, right? These are a sign of early stroke, folks, TIA. So when people have, so whenever a person diagnosed with a stroke, they must have had TIA. Either they didn't know they had it or they ignored it. Is that clear, folks? Because nobody can get the full stroke without any warning sign. Because remember, atherosclerosis and clot, it slowly develops, folks, unless it comes from different places. Okay, so that's TIA. Now, that's all about stroke. Is everybody clear with the stroke?
Dr. Roy, so this transient ischemic attack is not normal at all. Like, how do you differentiate when you feel dizzy and when you feel
See, when we feel dizzy, you know it, right? You are feeling lightheadedness and you are fainting. Once you faint, you won't regain consciousness that easily. But this is a couple of seconds and they come back absolutely to normal. Okay, and dizzy also very slow, right? You know it, you are feeling the dizzy and stuff. But this one, TIA, you have no warning sign, nothing. It all of a sudden happened for 5 seconds and then it comes back. You are completely normal. That's how you differentiate. Okay, all right. The best question to ask, how do you differentiate dizziness and vertigo? Because dizziness and vertigo is almost similar, folks. Okay, that we'll talk about it when we do the ear, but that's that. Okay, let's go back to movement disorder where we left. Okay, now vascular dementia. So that's your stroke. That's the second most common. Results of multiple arterial infarcts. Stepwise decline in cognitive ability with late onset of memory impairment. What is happening, folks? When people have a stroke, mostly they lose the memory as a last one before they lose everything else, right? Now, if you see, it's so hard to tell when people have a stroke whether they will regain all the function they lost or not. It depends on individual. There are people who had a stroke. After the stroke, they cannot move their right hand. There are people who had a stroke, entire half of the body is paralyzed, right? Some people go to physiotherapy and they get it back. Some people don't. So it is so hard to tell the prognosis of stroke until it happens and what we see on a patient, because we don't know which blood vessel is blocked, how much and how bad. Is everybody clear, folks? So when people have a stroke, you could never tell their family members whether the patient will regain the function or not. We don't know that. Okay, sometimes we tell them these people will never walk, but then they go to physiotherapy, it takes 6 months and they started walking slowly. Okay, so that's a stroke, but at least you know the memory is the last thing to do. Some people had a stroke, they lose the memory, but they can move all their body parts. No problem with the body parts, but they can lose just the memory, right? It depends on what blood vessel blocks that day, folks. It's like a sickle cell. You don't know which blood vessel is going to get blocked. Is that clear, folks? So that's stroke. Okay, now next one. Creutzfeldt-Jakob disease, the mad cow disease, right? Now, if you see here, this is a prion disease, rapidly progressive, weeks to months. This is a very dangerous, one of the worst disease, folks, okay? Dementia with myoclonus and associated with periodic sharp waves, EEG, and increase 14-3-3 protein on CSF. You need to know that. May be transmitted by contaminated material, folks, corneal transplant, neurosurgical equipment, and FET. There's no treatment for this. You get it, you are done. That's Creutzfeldt-Jakob disease, because prion disease are one of the worst disease, folks, okay? It's basically beta-plated sheet resistant to protease. We cannot destroy. Our body is not capable of destroying prion. That's the idea here. So once people get it, no treatment, absolutely no treatment. How do you get it other than the neurosurgical equipment and corneal transplant stuff? People who eat cow brain, folks, okay? People who eat cow brain is the one, those are the one. Not everybody. If the cow brain is infected with prion, you get it, okay? That's why in the United States, it's not legal to sell cow brain, okay? Because why? When you go to a meat store, it doesn't matter which meat store you go, meats are tested, but the brain is not tested because you cannot test it for prion, folks. So that's why they don't sell it. Even though brain is more tastier, they do not sell it. Okay, so that's the idea. Now, that's Creutzfeldt-Jakob disease, folks. Okay. Next, HIV-associated dementia. This is important. It's a subcortical dysfunction associated with advanced HIV infection, characterized by cognitive defects, gait disturbances, irritability, and depressed mood. I want to highlight this whole word. What's the macrophage of the brain? Microglial cells. The minute people have HIV and it's spread to the brain, the only way you could tell whether they have gone to the brain or not by looking at the microglial cell that shows multinucleated giant cells. That is the only way to identify is your brain has infected with HIV or not. Nothing else, folks, okay? So that's the idea here. That is the key. Review, I'm gonna pull up